स्टार्ट हो गया।
ये
कैसे मालूम पड़ेगा हाउ मेनी पीपल हैव जॉइन? जी ना। शुड आई वेट स्टार्ट? वेट फॉर फ्यू मिनट्स बिफोर स्टार्टिंग, है ना? वेट फॉर फ्यू मिनट्स। हाँ, few people more, let few more people join, then we will start, ना?
मुझे चेक करो आवाज में क्या आ रहा
Am I audible?
है इसका स्पीकर पर आ रहा है मैं नीचे फोन लेके चेक करता हूँ लाइक में स्टार्ट कर 10 लगाए थे, अब 6 लग बचे हैं।
हम्म,
वर्ड से कम होते रहेगा। ग्रुप में लिंक भेज दो,
हाँ,
एक बार डाल दो कि स्टार्टेड यहाँ से डाल दो।
इसका सेटिंग चेंज करके ना, मैं ग्रुप एडमिन वाला एक मैसेज भेजने वाला है, तो सेटिंग चेंज होगा।
अच्छा वो
हम्म, I think it's already 4 minutes since we are live, so we'll start now. So today uh, I am going to talk on very important topic, which is hyponatremia. As we know, normal sodium level is it's more than 135. Up to 145 millimole is considered as normal, from 135 to 145, and any level less than 135 millimole is defined as hyponatremia. Severity, depending upon different level, can be uh, defined as mild hyponatremia when the sodium level is less than 130 to between 130 to 135 millimole per liter, and moderate when it is between 125 to 130, and severe hyponatremia is when serum sodium level is less than 125. And it can be further divided into acute versus chronic. So any hyponatremia which can be documented that it is less than 48 hours is considered as acute, and if if you are not able to document this, then it is considered as a chronic, and especially when it is more than 48 hours uh, more than the initiation. Why this is important? Because in acute hyponatremia, correction can be achieved at a faster rate, but in chronic hyponatremia, correction has to be very slow. Because if we correct hyponatremia very fast in chronic hyponatremia, then there is a risk of central pontine demyelinosis, which is a neurological condition where patient can worsen. So hyponatremia is basically very common disorder, and it can be seen up to 22% of the hospitalized patient. And depending upon the clinical history and the volume status, it can be divided into three types. One is hypovolemia, hypovolemic hyponatremia, euvolemic hyponatremia, and hypervolemic hyponatremia. So as we see, depending upon the volume status, it can be divided into these three categories. So what is hypovolemic hyponatremia? Here the uh, serum sodium is low, along with the volume status of the patient is also low, and the volume status can be assessed depending upon the clinical and uh, clinical criteria based on the history and the physical examination. On the basis of clinical criteria, we can assess the volume status by if there is a history of nausea, vomiting, loose motion, or any hmm, extra volume loss because of the excessive sweating, or because of the some external loss happening because of the different drainage from the body. And if there is a edema or the feet or puffiness of face, then we think that the volume status is high, and in between is considered as normovolemic. So hypovolemic hyponatremia is basically characterized by true deficiency of both uh, sodium and water. And it happens because of the increase in the circulating level of arginine vasopressin level, and there is increased free water intake. Uh, because of that, it happens basically due to GI losses like vomiting, diarrhea, and different drainage, especially biliary drainage is there. In the biliary drainage, there is lots of sodium loss happens, and sometimes because of the severe insensible losses, especially when there is a sweating or burn, there is a lots of loss of fluid, and if patient doesn't take adequate amount of water and electrolytes, then he can develop hypovolemic hyponatremia. It can also happen in primary adrenal insufficiency when it happens at the level of adrenal, as compared to secondary adrenal insufficiency when there is a problem in the pituitary gland. There you get euvolemic hyponatremia. So in primary adrenal insufficiency, you get basically hypovolemic hyponatremia. Then there are different salt losing nephropathy because of the problem in the tubular absorption of the sodium. Lots of sodium is lost, and along with that, sodium water is also lost through the kidneys, and that leads to hypovolemic hyponatremia. And then same thing happen in different phases of acute tubular necrosis. And one more important common cause of hypovolemic hyponatremia is hazard diuretics, or any, for that matter, any diuretics like loop diuretics, Zatinax, and tablet like metalazone, and then chlorthalidone can also leads to uh, hypovolemic hyponatremia. But hyponatremia is more common with the thiazides group of diuretics. And many times we see patients having taking ASO-ARB along with the diabetics, especially elderly people where this sodium intake is restricted because of the concomitant hypertension, and we advise the patient to take less salt, and they usually develop this kind of hyponatremia, which is hypovolemic hyponatremia. And it can also happen because of the raised sugar, because of the sugar ketonuria, bicarbonate urea, and cerebral salt wasting. Because of the glycosuria, as we see in uh, uh, hyperglycemia or diabetic ketoacidosis, lots of sugar is lost in the kidneys, and sugar being osmotic molecules, uh, along with it, it drags the water from the kidney also, and that's why patient develops hyponatremia. And this patient also an entity called as pseudohyponatremia, which will talk later. And there is one cerebral salt wasting syndrome where lots of sodium is excreted via the kidney because of the hormonal changes happening in the brain, especially those patients who are having brain injury, subarachnoid hemorrhage, or intracerebral pathology. There are lots of sodium is wasted into the through the kidneys, and patient develops ultimately hyponatremia, which is hypovolemic hyponatremia. So basically, in terms of investigation, we do urinary sodium electrolytes. We check the sodium level in the urine, and if it is more than 20, then it signifies basically that the loss of sodium is occurring through renal uh, uh, losses. Kidney, via kidney, the sodium is getting excreted, and which can be seen because of the diuretics excess, like as I talk about thiazides, mineralocorticoid deficiency because of the adrenal insufficiency, salt losing deficiency, bicarbonate urea with renal tubular acidosis and metabolic alkalosis. Lots of sodium is being lost. Ketonuria, osmotic diuresis because of the sugar or mannitol, and cerebral salt wasting, as I told, which happens in the brain pathology patient, especially subarachnoid hemorrhage and intracerebral hemorrhage patient. And if the sodium concentration is less than 20 millimole in the urine, it basically signifies that the kidney is working properly, but the sodium is getting lost through the other pathway, which can be because of the vomiting, diarrhea, third spacing of fluid, the burns, pancreatitis, trauma. Then comes the another pathology, which is another type of uh, hyponatremia, which is hypervolumic hyponatremia, where the total body water is much increased as compared to total body sodium. And this typically happens in nephrotic syndrome, cirrhosis, or cardiac failure patient, where we see that patient has pedal edema, ascites, or fluids in the lungs, lots of extra water is there in the body, and but uh, despite that, and these patients have hyponatremia. So this entity is basically called as hypervolumic hyponatremia. Here the urinary sodium loss is less than 20 millimole per liter, but if it can be more than 20 also if patient is having acute or chronic renal failure. And in this condition, there is also patient is having generalized anasarca, so it is also called as hypervolemic hyponatremia. The most common hyponatremia which usually we encounter in the hospital or ICU setting is secondary adrenal insufficiency due to pituitary, and moderate to severe hypothyroidism with correction of after achieving your thyroid state, and syndrome of inappropriate antidiuresis, and this is called as euvolumic hyponatremia. Here the volume status is normal. Patient is neither dehydrated nor a patient is fluid overloaded. Volume status is normal, but despite that, patient is having hyponatremia. As I said, this basically happened because of the excessive secretion of antidiuretic hormone, arginine vasopressin, and that happens because of the stress, physical, mental, or surgical stress because of the pain or any other surgery in the body, or because of the exogenous secretion of arginine vasopressin hormones, and because of that, the excretion of sodium is increased, and it leads to retention of water in the body, and because of that, patient develops hyponatremia. In euvolemic hyponatremia, there is no edema in the body. Total body water is increased, but the total sodium may remain normal also. But since the total body water is increased, because of that, patient develops uh, uh, hyponatremia. Here, the sodium excretion because of the increased secretion of vasopressin is more than 20 millimole in the urinary electrolytes. And it usually happens because of the glucocorticoid deficiency, hypothyroidism, stress because of some drugs, and as I said, syndrome of inappropriate antidiuretic hormone secretion. Sometimes the hyponatremia can be seen because of the low solute intake, because of the excessive alcohol intake, that is known as beer protomania. Because lots of people drink some people drink lots of beer, and beer doesn't contain adequate amount of electrolytes like sodium. So because of that, they have more excessive water intake, and because of that, they develop hyponatremia. Extreme vegetarian diet and keto diet also leads to similar hyponatremia because of the similar mechanism. One most important thing which we come across is the pseudo-hyponatremia. Pseudo-hyponatremia is basically there is sodium level is normal, but because of the some triglyceride or some hyperproteinemia, like in multiple myeloma, because of the increase in the lipid concentration or increase plasma protein concentration in the body, sodium level doesn't get properly measured into the body, and its serum samples gets diluted, so it doesn't show. It shows less amount of sodium in the body because of the measurement error. So in that case, if you have to measure the sodium level correctly because of the presence of severe triglyceride level or hyperproteinemia, different laboratory methods are required to measure the serum level correctly. So this is called as pseudo hyponatremia, which is typically seen when the triglyceride level is more than 350, 400, 500 levels, and hyperproteinemia because of multiple myeloma. So these patients, if they are not symptomatic, they doesn't require treatment of hyponatremia. We have to correct the underlying pathology. So basically, how you diagnose clinically about the hyponatremia. So symptoms of hyponatremia basically depends upon its severity and the at which it evolves. If it evolves slowly, sometimes it becomes difficult to diagnose. But if there is a rapid change in the serum sodium level, it becomes apparent very rapidly. The symptoms primary are neurological due to development of cerebral edema within the rigid skull. Since the skulls cannot expand because of the swelling in the brain, the intracranial pressure rises, and it can lead to headache, lethargy, confusion, gait disorders, nausea, vomiting, and in severe hyponatremia, patient can develop seizures, coma, brain stem herniation, and it can lead to cardiac arrest, brain arrest and death also. So we have to be very careful. Many times, patients come with the any patient who is on antihypertensive and taking antihypertensive drug, which diuretics are prescribed. So we have to be very careful if he's complaining of nausea, vomiting, headache, uh, drowsiness, and sometimes convulsions. So we have to be very careful, especially elderly, and we think we should consider for the diagnosis of hyponatremia. And these are the symptoms which are primarily attributable to hyponatremia, but patient many times the hyponatremia is the secondary problem. Hyponatremia basically happens because of some or other in pathology, especially it can be indicator of some underlying hidden malignancy in the body. So we have to patient can have symptoms related to that also, and we have to actively look for the causes of hyponatremia in that particular patient. Acute and chronic hyponatremia we had already discussed. If it is less than 48 hours, it is called as acute. If it is more than 48 hours, it is called as chronic. But if we don't know when the hyponatremia is started, for all practical purpose and for the treatment purpose, it is considered as chronic hyponatremia. Sometimes patient with hyponatremia can have normocapnic or hypercapnic respiratory failure because of the uh, non-cardiogenic neurogenic pulmonary edema, with normal capillary wedge pressure. We have seen patients having a very low sodium, uh, uh, having a bilateral pleural effusion, some ascites also because of the decreased osmolality in the body. So, what are the common causes of acute hyponatremia? Mm, um, Usually, it can be multifactorial, uh, like as I said about the diuretics. It can be exercise-induced polydipsia, and sometimes we have seen a patient developing hyponatremia because of the peg leg given for the colonoscopic preparation also because of the lots of loose motion happening and excessive water intake during that period. Many times, acute hyponatremia also develop when the glycine used to be used during URB surgeries or uterine surgeries uh, because of the vascular supply being very good in the prostate. When you remove the prostate gland, the fluid which is given during the irrigation it starts getting absorbed directly, and if the surgery because of some or other reason gets prolonged, lots of glycine and free water starts getting absorbed from the prostatic bed, and it can lead to acute hyponatremia. So now this in our PG days, we used to see lots of glycine induced TRP related hyponatremia. But now, because of the uh, hmm, better understanding of this problem, usually urologists start using normal saline when they think that surgery is going to get prolonged. And sometimes if you use hypotonic fluid, especially in post-operative patient and where there is a surgical stress and pain because of the surgery, which leads to increased vasopressin secretion, and if you use more of a D5 or ringer lactate fluid, and then it can also lead to hyponatremia, and patient can develop acute hyponatremia within 1 or 2 days. Post-operative menopausal women can also develop acute hyponatremia, and sometimes we don't know the causes, so it is classified as iatrogenic. Sometimes patients have persistent hyponatremia because of the efflux of organic osmolyte like creatinine, betaine, glutamate, myoinositol, and taurine from brain cells. And many times, some or because of some other reason, we don't understand that we are using agents in the treatment of patient, and that can further contribute to hyponatremia. I will give the example. I had one patient who was constantly having low sodium. We had stopped the thiazide diuretics, but and we had given fluid restriction, some salt, but increased the salt intake, did the water restriction, but her sodium, she repeatedly used to get hyponatremia. So on further analysis, we realized that she was also receiving aldactone for the treatment of resistant hypotension. And aldactone, as you know, causes hyperkalemia and hyponatremia. So that the aldactone in this patient was as a reason for the persistent hyponatremia. So basically, in the diagnostic evaluation of hyponatremia, clinical assessment is very important. As I said, history is very important. Clinical setting of the patient is very important. If patient is elderly, we have to think of any underlying malignancy. If the patient is a case of CNS problem, then he is more prone to develop hyponatremia. So we have to use saline-based fluid in this patient. We have to assess his fluid and electrolyte intake properly, and we have to advise or give proper fluid in this patient. Uh, we have to also evaluate for the underlying cause. We have to take detailed history about his uh, symptoms, and on the basis of a clinical examination and history, we should try to understand the volume status of the patient because The causes of hyponatremia depend whether patient is hypovolemic, hypervolemic, or normovolemic. There are lots of drugs when patient is taking and that can be contributed to that can lead to hyponatremia. Or the drugs are chlorpropamide we don't use now. It used to be used earlier for control of diabetes. SSRI, even Serenase tablets can lead to hyponatremia. Tricyclic antidepressant, clofibrat, carbamazepine is very common drug which we used for control of neuralgia or convulsions. It can also contribute to hyponatremia. Nicotine, antipsychotic drugs, ecstasy drugs can also lead to hyponatremia. Cyclophosphamide, used for the chemotherapy, can also contribute to hyponatremia. Arginine vasopressin analog, desmopressin nasal spray, sometimes used in hypernatremic patient. If we don't monitor serum sodium level, this patient can develop hyponatremia. Vasopressin, when is used as a vasopressin in a persistent resistant shock, can also lead to hyponatremia. NSAIDs through prostaglandin inhibitors can also contribute to development of hyponatremia. So causes can be multifactorial, and we have to consider single or multiple causes, and we have to find out the uh, 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 what could be the cause in particular patient. Yes, we have to depend. We have to also look at the ABG analysis because that can also guide to the cause of hyponatremia. As I said, metabolic alkalosis can be seen in vomiting, and metabolic acidosis can be seen in diarrhea. This can be lead to hyponatremia. So, feature of low volume status on clinical examination can be diminished skin turgor, which can be seen in a severe acute gastroenteritis. Dry oral mucosa, more reliable sign of hypovolemia is low GVP, orthostatic hypotension or tachycardia, the rise in the pulse rate or drop in the blood pressure when patient is uh, stand up from sitting or lying position. And if patient is in shock, there could be periphery, cold periphery also. The important laboratory investigations which needs to be done for the diagnosis of hyponatremia is three tests. Serum osmolality, it can be two types. One is measured osmolality and the calculated osmolality. Calculated osmolality we do on the basis of electrolytes, sodium, potassium, sugar, and urea level in millimole. And serum measured osmolality is done in the labs from the serum sample. And in true hyponatremia, the plasma osmolality is generally less than 275 millimole. Normal osmolality is around 280 milliosmol plus minus 5. Then we have to measure the electrolytes in the blood and urinary electrolytes. Urinary electrolytes tell us the volume, can tell us about the volume status as well as the causes of uh, sodium loss from the kidney. We have to also measure the serum glucose level because, as I said, it is used in millimole as for the calculation of a measured calculated osmolality, and it is one of the contribution of pseudo hyponatremia. Sometimes when the sugar level starts going more than 100, for every 100 milligram increase in glucose level from 100 milligram percent, serum sodium level drops to 1.6. But when the sugar level goes more than 400, then the drop is more, 2.4 millimole as compared to 1.6. For example, if serum sodium level is uh, if sugar level in the blood is suppose 500, then you can have at least normal sodium level in these people will be almost 10 millimole less than the normal values. So 125 to 130 serum sodium level can be considered normal for a hyperglycemic patient. And serum uric acid level is also very important. It basically tells about the In SIDH type of physiology, serum sodium level is less than point 0.4 milligram per deciliter. So it also try to tell you what could be the pathology in that particular uh, patient, cause of hyponatremia. Urine osmolality is also measured in the lab, and all these investigations should be done before, if possible, before starting the treatment. Because once you start the treatment, you start giving saline, you start giving salt to the patient, then these values changes. Urine osmolality, especially urine osmolality and urinary electrolytes. So all these levels should ideally be measured before starting the treatment. A urine osmolality less than 100 milliosmol is suggestive of polydipsia. That means patient is drinking too much of water and the urine is getting diluted. So the extra urine is getting lost. So if urine osmolality is low and serum osmolality low, that means there is a polydipsia as a cause of hyponatremia. But if the urine osmolality is more than 400 millimole, that indicates that arginine or acidic excess is there in the body, which is the dominant cause of hyponatremia. And it happens because of the uh, uh, excess because of the arginine vasopressin level, which leads to excretion of sodium in the urine. And also we have to measure the serum protein and lipid profile level uh, to know to differentiate whether it is true or pseudo hyponatremia. As I said, because of the very high triglyceride and serum protein levels in multimodal biomarker, you can have a low serum sodium level with normal serum osmolality. Hypervolemic hypernatremia is already discussed that there is a proportionally great increase in total body water, and it happens basically in congestive cardiac failure, cirrhosis, nephrotic syndrome, and acute chronic renal failure. Where the serum urinary sodium level is less than 20, then the cause is in the kidney, liver, and heart. But if the urinary sodium level is more than 20, with hypervolemia, the cause is in the kidney. This we have already discussed. We have to also monitor thyroid, renal, and kidney function to differentiate between primary and secondary adrenal insufficiency leading to hyponatremia. And this is especially important if patient is having chronic hyponatremia or resistant hyponatremia that despite treatment, hyponatremia is not settling down. We need to also do some imaging investigation like X-ray chest, CT chest brain, or USG abdomen or CT brain, depending upon, because many times hyponatremia could be the initial marker of some hidden underlying malignancy. I had seen one patient of CA lung presented with hyponatremia. So this is basically interpretation of how the urine osmolality and serum osmolality and serum sodium, urinary sodium helps in diagnosing the possible cause of uh, hyponatremia. So if urine osmolality is low, uh, the cause could be less than 100 milliosmol per kilo body weight. Then cause could be polydipsia or beer protomania. But if urine osmolality is more than 100, consider the presence of antidiuretic hormone as cause of uh, mm, hyponatremia, where the symptom of inappropriate antidiuretic hormone is there. And if serum urine sodium is less than 12 millimole, it suggests the low effective arterial volume. That means patient is hypovolemic. But if serum sodium concentration more than 30, that means either the fluid is more or patient is uh, having normal volume status, or patient is using diuretics, which could be cause of hyponatremia. So coming to the most important aspect of management. So as I said, management basically depends whether the development hyponatremia is acute or chronic. If it is chronic, we have to correct very slowly to avoid the risk of osmotic demyelination. If it is acute, but in acute, as I said, we need to know with the help of history or prior investigation that it should be less than 48 hours. So it can be corrected fast, and the proper setting should be there, like uh, recent introduction of thyroid diuretics, acute severe acute gastroenteritis, or TRP surgery where the more of a glycine-based fluid was used, uh, then we need to correct it fast. But many a times it is a chronic hyponatremia where the sodium level drops slowly over a period of few days, and because of that there is this edema in the brain, and if, for that we need to correct it slowly so that the edema doesn't increases further and it doesn't lead to rapid changes in the sodium level in the pons, which is the reason for osmotic demyelination. And sometimes response to the treatment can be very unpredictable. Many times you give correction for 1 day, 2 days, and serum sodium level doesn't changes. That usually happens because we don't restrict the fluid in the initial first few hours or days of treatment, where the volume restriction, especially with hypervolumic or normovolumic hyponatremia, is important. And adequate amount of sodium should be provided to the patient to correct the hyponatremia. If patient is having hypovolemic hyponatremia, where the volume status is low and patient is having hyponatremia, and because of that there is a high level of circulating arginine vasopressin level. So here the if you give normal saline with in a adequate amount like 2 to 3 liter, 4 liter, 5 liter, depending upon the volume of dehydration, the hypovolemia usually gets corrected, and the brisk diuresis occurs, and there is a correction of hyponatremia happens only because of the institution of isotonic normal saline. But if patient is having hypervolumic hyponatremia, which is usually seen in congestive cardiac failure, renal failure, or cirrhosis or ascites, there the most important treatment lies the treatment of underlying, for example, if patient is having congestive cardiac failure, then treatment of underlying cardiomyopathy, cardiac problem with the help of ACE inhibitors, ARBs, diuretics, fluid restriction is important. If patient is having hyponatremia due to kidney problem and his patient is in the kidney failure, then along with the volume restriction, institution of dialysis in this patient usually corrects the hyponatremia. And there doesn't lie the role of 3% sodium chloride or excessive salt. Here the main uh, important thing is we have to restrict the volume, plus we have to remove the extra fluid. If we can, for that we can take either the help of diuretics if kidney is throwing urine. If kidney is not throwing urine, then we have to, like in renal failure, then we have to take the help of fluid removal through dialysis. So water deprivation basically has been cornerstone of therapy of the hyponatremia, and this formula basically gives how much volume we should restrict. The urine to plasma electrolyte ratio. Uh, in the upper is the urine sodium plus potassium divided by plasma sodium can be exploited as a quick indicator of electrolyte-free water excretion. Patient with ratio more than what should be more aggressively restricted. If your urine sodium is more than the plasma sodium, then urinary sodium more than plasma sodium, then you have to be more fluid restriction. You have to go more aggressive in fluid restriction, less than 500 ml per day. If urinary sodium and plasma sodium is more or less same, then you 5 to 700 ml fluid can be allowed. But if the urinary sodium is less than the plasma sodium, then you can probably give up to 1 liter of fluid. And if there is a concomitant hypokalemia, then it also should be corrected. If you don't correct the hypokalemia along with the hypomagnesemia, then it becomes difficult to control the uh, sodium level. So we have to correct the all the electrolytes like sodium, potassium, and magnesium. And many times, patient will require some drugs. So in that we have furosemide, especially with hypervolemic hyponatremia. And demeclocycline also works on the same line, especially those having renal tubular acidosis as a cause of hyponatremia. And the most commonly used drug is Vactans, and that is tolvaptan, which is basically an antagonist of V2 arginine vasopressin receptors, and it is drug of choice, especially with hypervolemic hyponatremia and euvolemic hyponatremia. But it cannot be used if patient is hypovolemic, and if the patient cannot produce urine. If patient is anuric, then we should avoid tolvaptan. Treatment of acute symptomatic hyponatremia should include basically 3% sodium chloride, and we should know how much sodium is there in 1 liter of 3% sodium chloride. It's almost 530 millimole. Normal saline contains 154 millimole of sodium in 1 liter, while 3% is almost 3 times more concentrated than the normal saline. So how we calculate the sodium deficit? It's basically 0.6 into total body weight into target plasma sodium minus concentration minus starting plasma concentration. So basically, if suppose if your sodium level is 105 and you want to make it to 110 in the first 12 hours, so it is 5 into total body weight is 60 kilo, and zero point 0.6 is basically 60% of your body is water. So zero point 0.6 into 60 into 5 comes to almost 218 millimoles, which comes to almost 200 to 250 ml of 3% sodium chloride, which has to be given over a period of 8 to 10 hours, so that your sodium level doesn't increases by 5 to 8 millimoles in that particular period, because rapid correction has to be avoided. Normally, you should not correct more than 6 to 8 millimoles, maximum 10 millimoles in first 24 hours, 12 to 24 hours, and it should never cross more than 48 millimoles in sorry 24 millimole in 20 millimole in 48 hours, because if you do too fast correction, then uh, uh, it normally should not get corrected 6 to 12 millicurrent per liter in first 24 hours and 18 millicurrent or more in first 48 hours. If you correct too much, then there will be risk of osmotic demyelination. And in chronic hyponatremia, you have to be a little more slow. So basically, if for example, if a patient comes with a serum sodium level of less than 100 and patient is very drowsy, comatose, and having one or two seizures, then how you correct it? Then in that case, you have to increase the initial 4 to 2 to 6 millimole in very fast, like in next 1 to 2 hours. So you give basically 100 to 150 ml of 3% sodium chloride over a period of 30 to 30 minutes to 1 hour, and that can increase the serum sodium concentration by almost 4 to 6 millimole in next few hours, and that can reduce the risk of ongoing convulsions, and it improves the sensorium of the patient, and subsequently you have to then again become very slow so that it doesn't increase by 8 to 12 millimoles in first 48 hours. So once you start the 3% sodium chloride, you have to measure the electrolytes every 4 to 6 hours, depending upon the cases, and minimum 12 hours you have to monitor the serum sodium level. But if patient is very critical like comatose, having convulsion, you have to give his serum sodium monitor serum sodium level every 4 to 6 hours also. So many times uh, question arises how much sodium at what rate we can give. As I said, if it is a very dire emergency, uh, uh,
Now, talking about the osmotic demyelination, in chronic or slowly progressive hyponatremia, if sodium level rises more than 20 millicurie in 24 hours, it can lead to changes in the brainstem, especially pontine area, and it can lead to dysphagia, Babinski sign, paraparesis, coma, and patient can worsen after showing initial sign of improvement. And worst thing is that MRI may not be able to detect the signs of pontine malognosis on the MRI initially in first few days. And it may take up to 4 weeks to show signs on the MRI. So that's why we need to be slow in treating hyponatremia, we need to avoid abrupt changes in the serum sodium level. Somehow it doesn't happen, central pontine malonysis doesn't happen if patient is having CKD or end stage renal disease, mm, because of some unknown reasons. But still, as far as possible, we should try to avoid fast correction of hyponatremia. That's why we have to be very, very vigilant. We should know how much sodium we needs to give. Usually patient doesn't need more than 200 to 50 ml 3% sodium chloride in the first 12 to 24 hours. So best thing is if patient is not very much having CNS signs and symptoms, like patient is having only nausea, vomiting, some mild letharginess, then you start with the 3% sodium chloride, either 10 or 20 ml per hour, and give it for 5 to 10 hours. Then measure the serum sodium after stopping the 3% sodium chloride for half an hour, 1 hour, and then see how much sodium has changed from the baseline. If it is in the targeted range, it has not gone up much, then you can repeat the 3% sodium chloride. If it has gone by 5 to 8 millimole, then you stop there. Then after 12 hours again measure the serum sodium level, and then again give 3% sodium chloride on the next day. Because sometimes we start so many treatment, we start the volume restriction, we give some diuretics also, we are going potassium also. So because of the multiple things happening together, sometimes the serum sodium level suddenly can go up. Only reason serum sodium level doesn't go up if the patient continues to take lots of fluid, or we give too many IV fluids, then only the serum sodium level doesn't go up. If you try to restrict the fluids to 500 to 1 liter, and we give 3% sodium chloride at a slower rate, and maybe some increase in the salt in the diet to the patient, then usually serum sodium level rises very smoothly, and the symptoms, all the symptoms of the patient also settles down quite well. I know it is very difficult. बहुत पहली बार कर रहा हूँ, तो काफ़ी टेक्नोलॉजी इश्यूज की वजह से समझ में नहीं आ रहा है कि किस तरह से करें, ताकि वो कहीं वो पीपीटी भी दिखाना है और आवाज़ भी आनी है। आई थिंक नाउ मैं इसको समराइज इस तरह से करना चाहूँगा कि बेसिकली हाइपोनेट्रीमिया हम लोग काफ़ी कॉमनली देखते हैं पेशेंट लोग के पास, स्पेशली एल्डरली पेशेंट काफ़ी कई बार अक्सर नाउशिया, वॉमिटिंग, वीकनेस, लेथार्जीनेस, इस तरह के अगर कोई भी एल्डरली पेशेंट सिम्टम्स लेके आ रहा है, और वो पेशेंट खास करके कोई डायरेटिक्स ले रहा है, तो हमको ये सब सस्पेक्ट करना चाहिए कि पेशेंट को हाइपोनेट्रीमिया है, और सीरम सोडियम लेवल मेजर करनी चाहिए। मेनी टाइम्स पेशेंट आते हैं इधर उधर मल्टीपल ट्रीटमेंट लेते हैं, इसमें लैब का भी बहुत बड़ा इंपॉर्टेंट रोल रहता है। अगर सीरम सोडियम लेवल प्रॉपर लैब से मेजरमेंट नहीं होता, तो कई बार हम लोगों को लैब रिपोर्ट नॉर्मल दिखाती है और पेशेंट को हाइपोनेट्रीमिया के सिम्टम्स रहते हैं। इसलिए प्रॉपर जगह से, प्रॉपर लैब से सीरम इलेक्ट्रोलाइट्स लेवल भी रिपोर्टिंग का होना बहुत ज़रूरी है। तो एक बार आपने डॉक्यूमेंट कर लिया कि पेशेंट को हाइपोनेट्रीमिया है, देन आप उसको फ्लूइड रेस्ट्रिक्ट कर सकते हैं। अगर फ्लूइड लेने की पोजीशन में नहीं है, तो स्लो नॉर्मल सलाइन चालू कर सकते हैं 30-40 ml पर आवर, और सिम्टोमेटिक पेशेंट ज़्यादा है तो 3% सोडियम क्लोराइड भी चालू कर सकते हैं। जैसे मैंने बताया कि 10 ml 20 ml यूजुअली स्टैंडर्ड ट्रीटमेंट रहता है। लेकिन अगर पेशेंट बहुत सही में बहुत ज़्यादा ड्राउजी है, बहुत लेथार्जिक है, कन्वर्जेंस आ रहे हैं, देन यू कैन गिव 50 to 100 ml 150 ml इन 1 to 2 hours, एंड तो थोड़ी देर के बाद 2-3 घंटे के बाद उसका सोडियम लेवल चेक करके देख सकते हैं कि अभी बेसलाइन से कितना गया। यूजुअली पेशेंट बहुत ज़्यादा सिम्टोमेटिक रहते हैं, तो शुरू के 3-4 घंटे में 4-5 मिलीमोल उनका बढ़ाया जा सकता है, ताकि उनके इनिशियल सिम्टम्स थोड़े कंट्रोल में आ जाए। उसके बाद जो बाकी, जैसे मैंने बताया कि पहले दिन में 12 घंटे में, 24 घंटे में 8 से 10 से ज़्यादा नहीं पड़ने चाहिए। जो बाकी 4 से 5 मिलीमोल रह जाता है, उसको हम उसको स्लोली करेक्ट करेंगे 5 से 10 ml 3% सोडियम क्लोराइड और ए पीरियड ऑफ 10 to 20 आवर्स या 5 आवर्स में देके, और फिर नेक्स्ट डे फिर से मॉनिटर करेंगे और उसके हिसाब से वो उसका सोडियम लेवल करेक्ट करने की कोशिश करेंगे। और फ्लूइड रेस्ट्रिक्शन के साथ साथ हम लोग कई बार पेशेंट लोग को बोलते हैं कि आपको सॉल्ट डाइट में बढ़ाना है, तो उनको एडवाइस करते हैं कि सॉल्ट बढ़ाने के लिए क्या करें। तो हम उनको पोटैटो चिप्स, मोनाको बिस्किट और चिवड़ा वगैरह, फरसान वगैरह खाने को बोलते हैं, जिसमें अक्सर सोडियम कंटेंट ज़्यादा होता है, क्योंकि सोडियम एक्स्ट्रा डाइट में खाना आसान काम नहीं होता है। एक तो पेशेंट ऑलरेडी नौशिया वॉमिटिंग कर रहा है, नौशिया हो रहा है, वॉमिटिंग कर रहा है, अगर आप सॉल्ट बढ़ा देते हो तो वो पेट स्टमक पे उसका असर होने की वजह से और वॉमिटिंग करने लगते हैं। तो हमें इस तरह से थोड़ा थोड़ा डाइट के अंदर एक्स्ट्रा सॉल्ट डाल के, या जैसे मैंने बताया नमकीन चीज़ें खा के, पोटैटो चिप्स वगैरह खा के, या फ्रूट्स वगैरह के अंदर भी नमक वगैरह डाल के खा सकते हैं। मेनी टाइम्स हम लोग पेशेंट को बोलते हैं सॉल्ट कैप्सूल इस्तेमाल करना है, 2 कैप्सूल दिन में 3 बार खाना है। तो उनको वो सॉल्ट कैप्सूल किस तरह से प्रिपेयर करना है वो मैं बता दूंगा। सोडियम क्लोराइड की टैबलेट भी मिलती है जो मेडिकल से खरीदी जा सकती है, वो 1 ग्राम की टैबलेट होती है, जो लेकिन वो उसका साइज़ इतना बड़ा होता है कि कई बार मरीज़ खा नहीं पाते हैं, तो उसको ब्रेक करके वो खा सकते हैं। लेकिन कई बार वो सोडियम जाते ही पेट के अंदर सडनली जो सोडियम रिलीज़ होता है उसकी वजह से पेशेंट वॉमिट कर देते हैं। तो हम लोग नॉर्मली क्या सजेस्ट करते हैं कि सॉल्ट कैप्सूल बनाना होता है। तो हम लोग क्या कहते हैं कि बीकोसूल या बीकोजिंक, जो सबसे चीपेस्ट कैप्सूल होता है, उसको आप लीजिए और उसको कैप्सूल को उस जिस तब आपको खाना होता है उसी टाइम उसको खाली करिए, उसमें नमक भरिए और 2 कैप्सूल खा लीजिए। तो कैप्सूल जब पेशेंट अंदर खाता है तो फिर वो कैप्सूल स्टमक में जाके स्लोली रिलीज़ होता है, तो उसका इतना पेट के ऊपर इफेक्ट नहीं होता, पेशेंट वॉमिट नहीं करते और आसानी से खा लेते हैं। वरना एक्स्ट्रा सॉल्ट खाना इतना आसान नहीं रहता है मरीज़ों के लिए, वो काफ़ी तकलीफ दे रहता है। तो इस तरह से करते हैं 2-3 दिन पे, और कई बार मजबूरन बहुत से पेशेंट एडमिट नहीं होते और हमको उनको घर के ऊपर भी ट्रीट करना रहता है। तो इस तरह से हम उनको एडवाइस करते हैं कि पानी आप उनको ज़्यादा ना दें, 1 लीटर मैक्सिमम 1.25 लीटर से ज़्यादा पानी नहीं पिलाएं, और खाने में डाइट में सॉल्ट बढ़ाएं, और इस तरह से सॉल्ट कैप्सूल इस्तेमाल करें। और सबसे इम्पॉर्टेंट चीज़ है कि जैसे जैसे जब जब हम ये हाइपोनेट्रीमिया में पेशेंट में डायग्नोस करते हैं, तो हमको चाहिए कि उसको अवॉइड करें। कई बार क्या होता है, लोगों को मालूम भी रहता है कि ये थायराइड डायबिटिक्स से है, और उसके बावजूद वो बीपी की दवा वही कंटिन्यू रहती है, उसको चेंज नहीं करते। तो वो चेंज करना बहुत इंपॉर्टेंट है। अगर हम उसको चेंज नहीं करें तो पेशेंट को बार बार हाइपोनेट्रीमिया होते रहता है। इसलिए सबसे इम्पॉर्टेंट है कि हाइपोनेट्रीमिया ट्रीटमेंट करने के साथ साथ आप उसके ट्रीटमेंट को मॉडिफाई भी करें और उसकी बीपी की दवाओं को चेंज करें। फॉर एग्जांपल पेशेंट अगर टेलमिसार्टन या हाइड्रोक्लोरोथायजाइड कॉम्बिनेशन ले रहा है, तो टेलमिसार्टन एम्लोडिपिन कॉम्बिनेशन पे शिफ्ट कर दो। एंड एक जैसे मैंने एक एग्जांपल बताया कि कई बार रेजिस्टेंट हाइपरटेंशन में हम लोग अल्डेक्टोन यूज़ करते हैं, तो एक तरफ से हमने थायराइड बंद कर दिया, लेकिन अगर हमने अल्डेक्टोन नहीं बंद कर दिया तो भी पेशेंट बार बार सोडियम डेफिशिएंसी होती रहती है और बार बार हाइपोनेट्रीमिया होता रहता है उसको। दूसरी चीज़ इम्पॉर्टेंट ये भी है कि उसके एक बार अगर किसी पेशेंट को हाइपोनेट्रीमिया डेवलप हो गया है, तो उसको आगे के लिए हमको उसको ये भी एडवाइस करना है कि जैसे नॉर्मली हम लोग ब्लाइंडली ये बोल देते हैं कि हर ब्लड प्रेशर के पेशेंट को कि आपको सॉल्ट नहीं खाना है, लेकिन नॉर्मली 3 to 5 ग्राम सॉल्ट खाना हर आदमी के लिए ज़रूरी है, क्योंकि वो नॉर्मल रिक्वायरमेंट है हमारी। तो 3 to 5 ग्राम सॉल्ट लेने के लिए उनको ये एडवाइस करना पड़ता है कि आप खाना जो हर आदमी घर के लिए सब लोगों के लिए बन रहा है वही आपके लिए भी बनेगा, लेकिन आपको ऊपर जो नमक, पापड़, चटनी, अचार, सैलड या रायता वगैरह में या छाछ वगैरह में जो यूज़ करते हैं उसको नहीं अवॉइड करना है, और नॉर्मल सॉल्ट इंटेक आपको मेंटेन करना है। तो अदरवाइज़ वो अगर सॉल्ट एक बार हाइपोनेट्रीमिया हुआ, मेडिसिन भी चेंज कर दिया, लेकिन अगर वो सॉल्ट इंटेक अपना बराबर नहीं रखेंगे तो बार बार वो हाइपोनेट्रीमिया आगे भी डेवलप कर सकते हैं। तो इन सब छोटी छोटी चीज़ों का, बातों का ध्यान रखना है। और दूसरी चीज़, कई बार हम लोग पेशेंट को हाइपोनेट्रीमिया डायग्नोस करते हैं, लेकिन हमको पता नहीं पड़ता है कि इसमें एटियोलॉजी क्या है। तो हमको हमेशा हाइपोनेट्रीमिया को लाइटली नहीं लेना है। कई बार हाइपोनेट्रीमिया अंडरलाइंग सीरियस बीमारी का इनडायरेक्ट इंडिकेटर होता है। तो अगर एक बार आपने हाइपोनेट्रीमिया डायग्नोस किया, आपने पेशेंट की लिस्ट देखी, लेकिन आपको समझ में नहीं आ रहा है इसको हाइपोनेट्रीमिया क्यों हुआ है, किडनी फंक्शन असेस कर लिया, थायराइड, एड्रिनल सब असेस कर लिया, देन वी हैव टू एक्टिवली सर्च कि कहीं पेशेंट को कोई मैलिग्नेंसी नहीं है। जैसे मैंने बताया इससे पहले, मैंने कुछ केसेस देखे हैं जहाँ पे हाइपोनेट्रीमिया बेसिकली पेशेंट को सी लंग की वजह से हाइपोनेट्रीमिया हो रहा था। देयर वाज सम मैलिग्नेंसी हिडन इन द बॉडी। तो इसकी वजह से और कई पेशेंट एक और इम्पॉर्टेंट कॉमन कंडीशन है, कई पेशेंट जो टीबी मेनिंजाइटिस के पेशेंट रहते हो उनको भी हाइपोनेट्रीमिया बहुत कॉमन रहता है। तो ऐसे पेशेंट, टीबी के पेशेंट अगर पहले इंप्रूवमेंट आया और फिर किसी वजह से डिटोरिएट हो रहे हैं तो उसमें भी हमको सोडियम लेवल का बहुत ध्यान रखना है। ब्रेन के जितने भी ब्रेन इंजरी के पेशेंट होते हैं या ब्रेन पैथोलॉजी के, इंट्रासेबुलर हेमरेज, स्ट्रोक वगैरह के जो पेशेंट हैं, इनके अंदर हार्मोनल इम्बैलेंस, आर्जिनिन, वासोप्रेसिन और जो सिंपैथेटिक नर्वस सिस्टम के इम्बैलेंस की वजह से भी सॉल्ट का या सॉल्ट सॉल्ट लूजिंग नेफ्रोपैथी होने की वजह से सॉल्ट एडवाइस होते रह सॉल्ट, एक्स्ट्रा सॉल्ट जो है वो लॉस होते रहता है। उसकी वजह से काफ़ी लोग बार बार हाइपोनेट्रीमिया में जाते रहते हैं। और हम लोगों को भी ये चाहिए कि एज ए डॉक्टर हम लोग ब्रेन पैथोलॉजी के मरीज़ों में ज़्यादातर सलाइन बेस्ड फ्लूइड का इस्तेमाल करना चाहिए और बहुत ज़्यादा एक्सेसिव फ्लूइड का इस्तेमाल नहीं करना चाहिए। पोस्ट ऑपरेटिव पेशेंट इज़ हैविंग प्रॉब्लम विद द पेन, बहुत ज़्यादा पेन हो रहा है, तो ऐसे पेशेंट में भी हमको सोडियम लेवल को प्रॉपर मेंटेन करने के लिए सलाइन बेस्ड फ्लूइड का इस्तेमाल करना चाहिए। अनफॉर्चुनेटली इसमें समझ में नहीं आ रहा है कि क्वेश्चंस क्या लोग पूछना चाह रहे हैं। देखता हूँ मैं अगर आई थिंक ऑलरेडी 1 घंटा हो गया है, हम लोग यहीं पे फिनिश करते हैं। इंशाल्लाह नेक्स्ट टाइम फिर कोई टॉपिक पे और अच्छे से बात करने की कोशिश करेंगे। इस दफ़ा शायद इतना अच्छा नहीं हो पाया, मे बी नेक्स्ट टाइम इंशाल्लाह विल ट्राई टू डू बेटर। थैंक यू। अब मैं सेशन एंड करता हूँ।